Hi, and welcome to this session of AI Med. I'm Dr. Arlen Myers. I'm President and CEO of the Society of Physician Entrepreneurs. And I'm pleased to have as my guest today Peter Horn, who is in the United Kingdom in Southampton, and Dr. David Berger, who is the newly appointed CEO of SUNY Downstate in Brooklyn. So, gentlemen, thanks for joining us.
Thanks for inviting us.
Sure.
Pleasure to be.
So we're gonna take a look at during this broadcast the issues that are confronting both of you as high-level executives, and I like to say you're both separated by a common language. Peter in the UK, David in Brooklyn. So maybe Peter, you can start off with just a brief background on who you are and what you do.
Sure. Thank you, and thank you for inviting me to be part of this. So my name is Peter Horn. I'm the Director of System Delivery within Southampton City Clinical Commissioning Group. For those colleagues in America, that's the equivalent of being a payor organization. I have responsibility for commissioning acute healthcare, hospital healthcare, long-term conditions, primary care. I also run emergency planning and response, organizational development, strategic estates planning. Right at the moment, I'm leading on the response to COVID-19, preparation for winter, and also EU exit for Hampshire and Isle of Wight, which is a population of about 2 million, workforce of about 30,000 people.
Doesn't sound like you have a lot of spare time, Peter. I'd ask you what your hobbies are, but that's kind of what's the point, right? Yeah. So, David.
So I'm David Berger. I'm actually a surgical oncologist by training. And as you can see from my current reading and the boxes in the back, that I'm day one Chief Executive Officer at University Hospital of Brooklyn, which is the major teaching hospital of SUNY Downstate Medical Center, actually where I went to medical school and did my surgical training. Most recently, I was the Chief Operating Officer at University of Florida Health, Central Florida, where I ran two hospital system and managed the COVID response for a community of about 500,000 people. Two hospitals, total bed count is about 650. And we experienced COVID a little different than my current facility did, and happy to talk about that later on. That's who I am.
Great. So yeah, we'll get to that in a little bit, but let's just cut right to the chase. And that is, you know, as high-level execs, admittedly in different roles and sort of different jurisdictions, what keeps you up at night? So David, you want to take that?
Sure. So I'm going to answer that in two parts. First is in terms of COVID-19, and secondly in healthcare and my new job in general. So first thing, in terms of COVID-19, what really keeps me up at night is the ability to keep our workforce healthy and on the job. And that has been a real challenge. So the issue early on came up about respirators and hospital beds. You could always find more. The real issue was, do you have enough people and can you keep them healthy to be able to take care of the large volume of patients being seen? So that has been a real concern of mine and has kept me up at night. How do we do that? How do we make sure that our workforce is staying healthy? How do we monitor their exposure? How do we keep them from getting our patients infected? How do we keep them from getting infected from our patients? So that's on the COVID front. On general healthcare front, there's an interesting article from Regina Herzlinger from Harvard Business School just out that says hospitals and as they currently exist or in any way, shape, or form are going to be obsolete in just a few years. I've heard that for a number of years, but certainly with digital health and moving outside of the hospital, as we've seen in COVID-19, there's real emphasis and a de-emphasis actually on hospitals as entities, as more and more of healthcare gets pushed out to the community and more digital telehealth is being used. So am I actually taking a job in an industry that in 5 years probably won't exist to any significant extent?
Dave, Peter?
Yeah, at the risk of echoing comments from David there, I think there's three things from my perspective. First one is about people, as David's talked about there. I've been concerned throughout the response since February, and I even more so now, about the ability to ensure that we can keep people going, as in the workforce, that they don't get fatigued, burnt out, or any other elements to that. Because certainly with the onset of winter and second wave of COVID in the UK, and then also we add in the EU exit dimension, there's a real risk around that. So I think that's something that worries me about how we managed to do that through the various hospitals and systems. Second point from me would be about patients, and not so much about the patients who've had the misfortune to have COVID-19. It's actually the patients who are sick or ill because they don't have COVID-19. That was obviously another element that we had to get the balance right, both at a national and a local level, and that continues to be an issue, I'm sure, for every health system. But as we try to recover what we're doing, it becomes even more of an issue. And that leads me to my third concern, which is looking over the horizon about potentially a missed opportunity around health inequalities, and how we try to get more prevention and early intervention into the way that we deliver healthcare in the future. We were starting to do okay in Hampshire and Isle of Wight. COVID-19's sort of driven a coach and horses through that. And the risk, I think, for the next couple of years, both at a national and a local level, is about more of a focus on treatment for people and addressing the waiting lists. And I've got a feeling that's where all the money's going to go. And my concern is that if we don't address the prevention and early intervention agenda, we end up adding to the problem rather than actually solving the problem.
So I just want to follow on what Peter said. We've seen what I like to call as COVID neglect syndrome. So people afraid to go and get health care, ending up with much worse problems. So we've seen, even though the volume in our emergency departments declined by almost 40%, we saw a 25% increase in mortality from stroke and cardiac arrest. Recently there was an article about NHS and the possible risk and the decrease in cancer-related mortality because people are not getting the recommended screening. So really, we are neglecting other illnesses because of the focus of COVID-19. So I think, Peter, you're right on the mark with that.
So you both have been charged with managing the COVID response. And so I'm interested in sort of like a compare and contrast between your experiences, and then introduce the notion of what is the role of technology, or what has been the role of technology. Most people point out telemedicine was sort of their initial foray. Some were prepared, some weren't, but it extends to remote patient monitoring, big data, interoperability, remote sensing. I mean, the list goes on and on and on. So I wonder if you could kind of address those overlapping points, and that is, how do you compare your responses to COVID, and what was the role of technology in the issues? So maybe, David, you could start.
Sure. So, I managed this in Florida, which was very different than other places like New York that got hit very early on. So in Florida, when the first wave came in places like New York, Washington, et cetera, were experiencing their peaks, and the whole country sort of shut down for a period of time, we actually didn't have a lot of patients. So we did not have a lot of patients in our hospital, but we had shut down our ORs, or all our elective procedures, and tried to get telehealth up very rapidly. The one thing that I was really concerned about in our hospitals is we had open ICUs. We didn't have focused intensivists taking care of patients, and the COVID patients were extremely complex. And so we very quickly got an EICU up and running, and that was supported by intensivists from the University of Florida Health, and that was really critical. And then certainly we had band-aid approaches to telehealth. So we did urgent care, had a telescreening program. We developed telepsych very quickly for both people in the community and for our workforce. But we really, band-aided the solutions in terms of being workable. And we were able to achieve what we needed to achieve for the emergency, but certainly in terms of sustainability, that is probably not the best approach. But we were able to get things up pretty quickly to get done what needed to be done within the emergency situation. But the key was really the EICU in terms of managing the really sick patients.
Peter?
Yeah, so from my perspective with the response, we sort of had two strands to the response. One was very similar to how David's described things in terms of generating critical care capacity, converting areas of hospitals into so they could take a lot more respiratory patients, and changing the ratios for staff who were supporting patients who were in intensive care. So that there was I would say that's a more around capacity and workforce side of things, and there was technology to support that. The second strand to the response in Hampshire and Isle of Wight was around shielding and protecting people from getting so shielding people who were vulnerable and protecting people from not getting the virus in the first instance. So that meant people at home, that meant people not sort of going out, that meant support packages going in to support them, but also that became an opportunity from the technology point of view to be able to ensure that people were sort of safe and could use some of the sort of telemedicine, those sort of telemedicine equipment that was already in place. And picking up on David's theme there, I actually wrote down before this meeting that necessity is the mother of invention. And I think there was a lot of things where they were sort of jury-rigged together, or however you want to describe that. But there was a focus on being able to support patients and the population outside of hospitals so that they don't get the disease in the first instance, thereby us not overloading the system, the treatment system. I think the most profound change that we had in place, that got put in place very quickly, was the way that GPs or primary care were interacting with their patients. So again, the notion of people going to visit their GP went out of the window, and very quickly a lot of very simple and commercially available technology was deployed to be able to support that. And that is an area where I think there's a real opportunity for the future. The other area where I think there's a real opportunity is in terms of putting all the elective care, however we're going to manage elective care in the future, there's an opportunity there to ensure that outpatient, in particular, outpatient consultations can be done online and are more convenient for the patient.
One of the big challenges we had, and I think a lot of other people had, was communicating with families. Having the patient being able to communicate with their family, because I think most places were limiting visitation, and we, for a period of time, actually shut down visitation. And how do you facilitate that visitation in a way that the family can understand what's going on, communicate with their loved one, and if their loved one is critically ill, how do you generate enough time for the caregivers to be able to provide that necessary one-on-one to update the families? That was a really big challenge we had throughout. The nurses were burdened with a lot of other activities, and being able to communicate with the families was a real big challenge.
Yes, and that was a similar. We got similar examples of that, not just in where I am, but also quite a lot of media coverage around the work that nursing staff in particular were doing within the critical care environment which was quite it's quite heartrending actually when you see it, people actually having to communicate their via a nurse to be able to pass on the wishes of the family as the patient expires.
And a big challenge for us was the burden of the work on the nurses, because you didn't want the food and nutrition people delivering trays, so the nurses had to deliver trays. You didn't want to limit the amount of time that environmental services were in the room, so the nurses were responsible for a lot of environmental service work. After initial visits, a lot of the doctors wanted to do the visits virtually. They didn't want to see the patients. So it really became a huge burden on the nursing staff, both physically, emotionally, as well, because they felt, why should we be continually put at risk? Why are others not sharing the burden? So figuring out how we can apply digital solutions to unburden the nurses is really, I think, critical.
I'd say the other opportunities that, or the areas that I'm looking to focus on from how we get IT to be able to support us is again going back to that point about shielding patients, or not just shielding patients, is enabling.
So knowing what you know now, but you didn't know then.
Go ahead.
Arlen?
Didn't know then, what would you have done differently, and how will this inform your thinking moving forward?
Peter, you can go first this time.
I knew you were going to say that. I knew. What would I know? Knowing what I know now, what would I do differently? I would have. I know this is supposed to be about IT, but I think the thing I would do differently is I would have focused on logistics and PPE quicker. I reckon about 2 weeks behind where I needed to be on that. But that aside, from an IT perspective, I think the main bit would be around ensuring that there was more support for people in their own homes, even if it was just off the shelf, that we were able to put that into position, particularly in nursing homes, a bit quicker than we did.
The other thing that I'd like to add to that, and I agree with what Peter has said, is the contact tracing has been really a challenge. I know a lot of different digital solutions, and some of the big guys are trying to build into their smartphones ways of doing it, but the contact tracing has really been a challenge, and who was really a contact, who wasn't a contact. So I think if we had a better way of doing that early on, that would have helped tremendously. The thing that made a difference for us was the ability to get rapid testing. That was game-changing, because when it first started, we had up to 100 PUIs in the house every day, which were burning through PPE, burning through staff. And once we were able to do rapid testing and figure out actually who had COVID, it made a world of difference and totally eliminated that challenge. But being able to do contact tracing and using some kind of digital monitoring would have been really helpful.
So we'd be remiss if we didn't talk about AI, since this is AI Med. And so my question is, in your mind, what role is or will artificial intelligence play in managing your organizations? And do you simply just have bigger fish to fry, or is that an integral part of the solution at this point? Peter?
I would say I could see it being part of a solution particularly for primary care. We've got an emphasis on primary care within the UK system, and I think that would help to help primary care clinicians to be able to manage the demand that's coming at them, And by doing that, we then ensure that there's the patients get to the right place first time, as it were. So I think for me, it'd be around primary care and 111, which is our non-urgent call centres service, which is a national service. I think that's where I would see the applicability of it, to ensure that you could get the patient to the right place for the first time, and thereby manage demand in a way that means you're not overwhelming, particularly in the last cases, the ERs, and that patients can get what they need, but in a smart way.
Yeah. So,
and we have a question. Go ahead. Go ahead, David.
No, we'll answer the question if there's a question.
David?
Yeah, so I
well,
think
the question is similar to it, and that is, the question is similar, not just AI, but digital therapeutics, remote sensing, sort of all the things we've been hearing about. And how do you put all those together without having to create like an independent stack of apps and modalities that lack interoperability? So when you tie it all together, how do you create a whole product digital health solution?
if I had the answer to that, I'd be a very rich person. That's the challenge. Especially from a hospital administrator point of view, that is the big challenge. There are a lot of digital solutions, a lot of AI solutions out there right now, but none of them are really cohesive and coordinated into a suite that is really plug and play and can be readily adapted. There's so much out there that it's hard for someone like me to pick out what's of real value and what's not of real value. What I look for in a solution is it addressing a big problem? Who's the team behind it? And what is their implementation plan? So you may have a great whiz-bang solution, but if you don't have a solid implementation plan that you as the company are going to help with, it really makes it challenging, because hospitals run on very tight margins, and we don't have a whole army of people to be able to implement and sort all these artificial intelligence and digital solutions. But we have, in one of my previous hospitals, implemented AI already. I believe if you're in a hospital, you should be monitored continuously, not have vital signs every 4, 8, 12 hours. And all that information that is in the medical record, and all, as well as the vital signs, should be synthesized to identify patients who are experiencing clinical deterioration, so we could get to those patients sooner. So we've done that, and it can be done already. And so I think that's an important application of AI. And then being able to take what's in the electronic medical record, and from a hospital administrator point of view, being able to couple that to operations, prioritize who gets an x-ray when, what lab tests need to be done on who, what kind of post-acute care patients are going to need, being able to marry that information that we now have in a lot of our EMRs to actually operationalize and get patients through the process quicker and identify where their best care setting is really what my goal would be in terms of being able to implement AI. But there's so much out there right now, it's really hard to figure out what's of value and what's not of value right now.
Peter?
Yes, I'd agree with that. I mean, I think that, there's always a risk that people try and sell you snake oil, and I'm a big fan of trying to keep things as simple as possible, because I'm a simple person myself. It's not so much about the technology; it's more about the behaviours that it can support and drive, and that's why I try and favor keeping it as simple as possible. Of course, working in the NHS, phrases like NHS and IT transformation never go together quite that well, because we've got a history of not being very good at it. That's not to mean the reason we shouldn't be doing it better, but there's a basic requirement, I think, within the NHS just around interoperability, frankly. if we can get the interoperability between all the systems that there are, so a GP system can actually talk to a hospital system, talk to social care system, that would be a march forward, even just that, getting that first time. I think then we can move on to some of the other bits, or run them in parallel. But there are some barriers for us, given the way that the NHS is configured and the political dimensions to it.
And Peter points out an important point. It needs to be simple, and it needs to decrease the work of the person you're asking to implement it. If it causes them to have to do more things or to input, or they end up getting more work because of the solution, it's never going to work.
So one of the challenges, as we know in sick care, which is what I call it, or ultimately healthcare, is you have to satisfy the interests of multiple stakeholders. And in this particular instance, it's not just about the patients or the people taking care of them, but it's about the C-suite, it's about the IT people, it's about the payers, it's about the CFO, the CMIO, and all the other CXOs. And the challenge is, how do you satisfy all those folks with a solution? And how do you align them? We don't have a whole lot of time left, but I'm wondering if, keeping that in mind, in creating the brave new world as we come out of this, what are you thinking, or what would you like to share as a final comment about your strategic plan or your strategic thinking? We've heard, obviously, the importance of technology, digitization. We've heard about motivating people. We've heard about protecting people. We've heard about the migration of hospitals, the care now in hospitals migrating out of hospitals into the home. So given all of those trends, what does your, these days a strategic plan is like, what are you going to do tomorrow? So what does that look like? Because, relevant to your 90 days, if I recall from that book, the first 30 are you listen, the second 30 are you put up a plan, and the third is you put some points on the board by the end of 90 days. You may or may not agree with that, but that's the general idea. So what does your future of your organization look like? Let's say COVID goes away tomorrow. What would your organization look like in 6 months compared to what it looks like today? Peter, final comments.
So you're speaking to a man who's going through a restructure right at the moment. So my organization's merging. So in 6 months, it's going to be very different. But I would say, I would like it to be able to pick it, going back to the initial questions you asked around what keeps me up at night, trying to address those. And for me, it's the missed opportunity. So which for me was around prevention, early intervention. I'm fairly sure that most of the money that's going to be allocated nationally to all our systems is going to be hosed into treatment. I haven't got a problem with that, but that's where it's likely to go. And I'd like to start putting a dent in the ability to address the prevention and early intervention side of things, which in the parlance at the moment, some people talk about population health management. I'd like to at least be able to, in 6 months, be able to have some sort of plan. And I think technology has a big role to play in that, because that is about systems integration or integrating data and big data to be able to help us address some of those issues, so we can be far more predictive in what's going on. I know it's a bit of a nirvana for people, but if I could get if I end up with the right job, if I could get my organization to start down that road, seriously start down that road, not just talk about it, that would be a success for me in 6 months' time. We may well have got maybe one pilot or a project up and running in a part of Hampshire and Isle of Wight, which would probably, rather selfishly for me, be Southampton City, because that's the place I know.
So to me, technology is not a cure. If you have an organization,
David?
So to me, technology is not a cure. If you have an organization that has, fundamental process issues, and you try to throw a complicated technology solution on top of it, it's doomed to fail. So my next 6 months is really putting process in place and basic blocking and tackling in order to get this organization on solid footing before I even start looking at digital solutions. The one thing that I would try to push forward is we're in central Brooklyn, which was one of the really most hardest hit areas in New York City. And we have a very socioeconomically disadvantaged, diverse population. And what we need is to be able to reach out to people in their homes to track how they're doing post-COVID and see what the long-term impact on COVID, on having COVID is in this population. So that's really where I need to focus in terms of my digital efforts and sort of what Peter's talking about in population health for that specific population.
Well, we're out of time, unfortunately, so I both want to thank you very much for your participation and insights. David, best of luck in your new role. Peter, best of luck in all of your roles, and hopefully we'll see you again on AI Med. Thanks very much.
Thank you, guys.
Thanks very much. Bye.
Bye.